Greetings, everyone. This is Miss Gibson. This is going to be lecture 2 of the immune system. Here are your objectives. The first thing we're going to talk about is hypersensitivities and allergies. So hypersensitivity or allergy, the terms are used interchangeably, is an overactive immunity in response to an antigen. An antigen is a foreign protein or allergen to which one has previously been exposed to. And the book gives you this acid as a way to remember it: anaphylaxis, cytotoxic, immune complex mediated, or delayed. While immunity with inflammation is protected and helpful, overactive response towards normal body tissue can cause damage. Hypersensitivity is, as we've already said, overactive immunity in response to an antigen. It can range from itchy, watery eyes to life-threatening, which would be your asthmatics or anaphylaxis. And this is discussed in your book. On chapter 17 starts on page 333. The 4 different types is discussed on page 334. Type 1 hypersensitivity, also known as anaphylactic reaction or immediate reaction, is the most common type of hypersensitivity arising from excessive inflammation caused by overactive immunity. Usually the target of the action is appropriate, but the body's responses are excessive. Type 1 reactions result from the increased production of the immunoglobulin IgE antibody class. And then type 2, which is your cytotoxic mediated responses, occur when the body makes autoantibodies directed against self cells that have some form of attached foreign protein. The autoantibody binds to the self cell and forms an immune complex. The self cell is then destroyed along with the attached protein. Select examples of type 2 reaction include drug-induced hemolytic anemia and hemolytic transfusion reactions when a patient receives the wrong blood type during a transfusion. Next, you have type 3, which is immune complex. These reactions result from excess antigen causing immune complexes to form in the blood. These circulating complexes then lodge in small blood vessels of the kidneys, skin, and joints. The complexes trigger inflammation and tissue or vessel damage occurs. Most autoimmune disorders are caused by type 3 reactions. The last one is type 4 hypersensitivity reaction. This is also called delayed type hypersensitivity reaction. This occurs 12 to 72 hours following exposure. Following exposure, sensitized T lymphocytes respond by releasing chemical mediators and triggering macrophages to destroy the antigen. Common examples of type 4 reactions include contact dermatitis, skin irritation that arise following exposure to poison ivy or certain jewelry metals. Or you could also classify the local response to insect stings and sarcoidosis. Sorry, forgive me for completely messing that one up. So, as we talked about, type 1 is the atopic allergy. It's the most common type, increased production of IgE. Your contact methods are inhaled, injected skin and mucous membrane. Acute inflammation occurs when IgE responds to antigen, which causes histamine and vasoactive amines to be released from basophils, eosinophils, and mast cells. Reactions can be localized, excuse me, or more widespread, which would be the anaphylaxis, where all blood vessels, bronchial, smooth muscles with blood vessel dilation, decreased cardiac output, and bronchoconstriction. Mechanism is same regardless if localized or widespread. So the mechanism of action would be upon first exposure, antigen-specific IgE is made. The IgE binds to surface of basophils and mast cells. Many cells have granules containing vasoactive amines, including histamine, that are released when stimulating. Once formed, IgE sensitizes to the allergen. Then there is re-exposure. The primary phase of re-exposure is when the allergen binds to IgE surface of basophil and mast cell, alters cell membrane, and vasoactive amine is released. The most common is histamine, which is short-acting, causes capillary leak, nasal and mucus secretions, pruritus, erythema, when continuously present. The response is prolonged when the allergen is present. Then you have a secondary phase. This is release of other cellular proteins, drawing more white blood cells to the area, stimulating a more general inflammatory reaction through leukotrienes and prostaglandins. Production of increased IgE levels in response to antigen exposure is genetically based in inherited genes, although specific allergies are not inherited. Penicillin is individualized, so that just means that just because mom and dad are allergic doesn't necessarily mean that you are going to be allergic. Angioedema, this is a severe type 1 hypersensitivity reaction that involves the blood vessels and all layers of the skin, mucous membranes, and subcutaneous tissue. Unlike the superficial responses of allergic rhinosinusitis, the angioedema response is a deep tissue problem of IgE mediated release of inflammatory proteins, especially bradykinin. Although angioedema can occur in any part of the body, it is most often seen in the lips, face, tongue, larynx, and neck. It can also occur in the arms, hands, legs, feet, or in the genitalia. Intestinal angioedema can also occur, characterized by severe abdominal pain, cramping, nausea, and vomiting. This can be difficult to differentiate from another acute abdominal problem. Exposure to any ingested drug or chemical can cause angioedema. The most common drugs associated with angioedema are angiotensin converting enzyme inhibitors and NSAIDs, as well as aspirin. We're going to talk about anaphylaxis. That is another type 1. This is the most life-threatening. With anaphylaxis, it is a condition in which a type 1 hypersensitivity reaction involves all blood vessels and bronchial smooth muscles. It causes widespread blood vessel dilation, decreased cardiac output, and bronchoconstriction within seconds to minutes after allergen exposure. It is the most life-threatening example of a type 1 hypersensitivity reaction, occurs rapidly and symptomatically, and can be fatal. The major factor in fatal outcomes of anaphylaxis is a delay in the administration of epi. Drugs and injectable imaging contrast media are some causes of anaphylaxis in acute care settings. Food and insect stings or bites are common causes in community settings. So, with anaphylaxis, we know the first intervention is going to be assessing the airway. You want to assess if they're having good gas exchange. You're going to make sure that they have IV access. If the epi has not been given at home, you're going to go ahead and give it. You may see an order for Benadryl, IM, or IV to treat the angioedema. Increase the head of the bed. If they're having trouble breathing, you're going to put them on oxygen. They may also be given corticosteroids. The next thing that we're going to talk about is rhinosinusitis or hay fever. This is triggered by immunity and inflammatory reaction to airborne allergens such as pollen, mold, dust, animal dander, wool, food, or air pollutant. Some are seasonal, only lasting a small amount of time each year. Some continuous with exposure to allergen. Usually only superficial layer of skin or mucous membrane in the blood vessels are affected. Some symptoms: pain over cheeks, radiating into teeth, tenderness to percuss, referred pain to temples, back of head and general face pain that increase when you lean forward. Management is focused on symptom relief and education. Drug therapy might be decongestants that constrict blood vessels and decrease edema. Antihistamines, leukotriene inhibitors, and mast cell stabilizers. They block or reduce chemical mediators and prevent local edema and itching. And then your analgesics for pain. So with your type 2, the body makes autoantibodies directed to self cells that have a foreign protein attached to them. Autoantibody binds to self cell and forms immune complex. The self cell is then destroyed. So this is examples of this would be immune hemolytic anemia, immune thrombocytopenia, hemolytic transfer reactions. When you transfer the wrong blood, there's a matching type problem, or drug-induced hemolytic anemia. So management would be stop offering the drug or blood product and treat the symptoms. Complications would be kidney failure or hemolytic crisis. Plasmapheresis, which is where you filter the plasma to remove specific substances during administration, may be beneficial. But of course, that would be up to the doctor. Next is type 3. This is where you have excess antigens that causes complexes to form in the blood. Circulating complexes lodge in small vessels of kidneys, skin, and joints. Triggers inflammation resulting in tissue or vessel damage. Examples of these would be your rheumatoid arthritis, lupus, glomerulonephritis, goodness gracious, and then arthritis as well. Common causes of, you may also have this serum sickness, which is received serum or certain drugs. Common causes of this serum sickness is penicillin, some types of antibiotics. You have fever, achy joints, rash, malaise, enlarged lymph nodes, possible polyarthritis, and nephritis about 7 to 12 days after receiving causative agent. So teaching would be monitoring for symptoms and keep emergency equipment available, which would be your EpiPen. And then type 4, this is your delayed hypersensitivity reaction. T lymphocytes or T cells respond to antigen and trigger macrophages to destroy the antigen. Occurs hours to days after exposure. You're going to have edema, induration, ischemia, and tissue damage at the site of exposure. Example would be your PPD if you were previously exposed. The reason for the PPD induration would be the T cells clump at the injection site. There's a release of lymphokines, which activate macrophages. The induration would appear 24 to 72 hours after exposure. Or contact dermatitis with exposure to poison ivy. Insect stings would also be a delayed hypersensitivity reaction as well as a transplant reaction. Next, we're going to talk about autoimmunity. Autoimmunity is discussed on page 341. It is a process in which an inappropriate immunity develops to a person's own tissue. In this response, the body's antibodies and lymphocytes are mistakenly directed against the body's own healthy, normal cells and tissues, not just against invaders. The immune system loses some degree of ability to tolerate self-cell and tissues. Autoimmune disorders are common, chronic, progressive, and incurable, although periods of remission sometimes occur. The incidence of autoimmunity within the global population is nearly 4%. Studies confirm that there is a definitive genetic component that contributes to development of autoimmune diseases. And then if you look on page 341, there's a box at the bottom of the page. It's box 17.5. It's common autoimmune disorders. You do need to look over those. All autoimmune diseases have inflammation that can damage tissue, also cause increased cell growth of skin, which is what you see in psoriasis. General, some medications that might be given to help with that would be corticosteroids. They suppress the bone marrow white blood cell production, inhibit immune response, as well as the inflammation response, and greatly increased, which will greatly increase the patient's risk of infection. So they are used very sparingly. Then you have cytotoxic drugs. This is purposely destroy cells commonly used in cancer, more sensitive to rapidly dividing cells. The white blood cells are suppressed, used in lower doses in autoimmune disease as decreased white blood cells along with immunosuppressive therapy. Then you'd also have some selective immunosuppressant therapy, which may be used alone or in combination with general immunosuppressants. You'll have anti-proliferative drugs. They slow the growth of immune system cells responsible for autoimmune disease. You'll have disease-modifying rheumatic drugs as well as biologic disease modifying antiarrhythmic drugs. Make sure that you look up these different medications. There will also be some extra resources in Blackboard that you can go through to look over each of these medications, but those are all very important that you look through and know for testing purposes. Next is the immunosuppressive therapy. This is just going over each type of medication. We've talked about a lot of these, the corticosteroids, cytotoxic drugs. Then your selective immunosuppressive therapy. As I've already stated, you will need to know these medications. I will have extra resources available for you guys on Blackboard where that you will just have a general overview of what is expected. Now we're going to have some practice questions. The nurse has educated the patient with a shellfish allergy about signs and symptoms of angioedema. Which patient statement requires further education? So A, I can eat shrimp because it is not a shellfish. Why is this correct? Shrimp is a shellfish and should not be consumed by a patient with shellfish allergies. This statement, therefore, requires further teaching by the nurse. The patient should carry an epi injector at all times. Symptoms of angioedema include swelling of eyes, lips, and tongue. Patients should report all allergies to healthcare providers, as we well know. A patient has been admitted to the ED with bilateral eyelid swelling and difficulty seeing. What is the priority nursing assessment? This should be easy for you guys, your ABCs. The patient likely has angioedema that has caused the swelling. This can progress very quickly to affect the airway. Interventions focus on stopping the reaction and ensuring adequate airway. While swelling can invade the nasal cavity, it is likely caused by a home medication. The priority is on securing and maintaining the airway. A history of visual disturbances is unrelated, as vision will likely return when eyelid swelling is decreased. A nurse is administering a new medication intravenously to a patient. The patient becomes short of breath and begins to experience itching and hives. What is the priority nursing response? You're going to stop the IV drug. Stop the drug immediately, but do not remove the venous access because restarting of an IV is very difficult in severely hypotensive patients. The other options can be done after the new medication infusion is stopped. Which nursing intervention should be attended to first for a client with a type 1 hypersensitivity reaction? Establishing and maintaining an airway. Remember your ABCs. Which of the following clinical manifestations suggest a type 4 hypersensitivity reaction? Dermatitis from contact with poison ivy. We know that the type 4 is a delayed reaction. So next is a case study that I have that we're going to present you with. A patient comes to the ED with shortness of breath, facial edema, reporting rhinorrhea, a runny nose, and a severe headache. The triage nurse notes that the patient's lips and eyes are very swollen. What assessment history question should be asked at this time? So an accurate and detailed history is important. The patient should be asked to describe the onset and duration of problems related to possible allergen exposure. Ask about work, school, home, environments, possible exposure through hobbies. The patient should also be asked about the presence of allergies among close relatives because of the tendency for type 1 allergies to be inherited. The nurse asks the patient if she has allergies. The patient states that she has an allergy to peanuts, but has not had anything to eat today. The nurse also states that she worked early today as a nursing assistant. What laboratory test should the nurse anticipate the provider will order? So, an immunoglobulin E, as well as a CBC with diff. So with the CBC with diff, you're going to look for increased eosinophils, which may be as high as 12%. Normal is around 1%. Some patients may also have a higher than normal total white blood cell count. Normal IgE levels are about 39. This level is greatly increased with allergies. Based on the patient's history of new onset of shortness of breath and edema of the eyes and lips, what does the nurse suspect is the problem? The nurse anticipates that the patient may be having an anaphylactic reaction. The patient stated that she was allergic to allergies. This allergy has been linked to contact with latex gloves. Not Lasix, the medicine. Goodness gracious. Because the patient has been working prior to presenting to the ED, the nurse should inquire about her use of latex gloves during her shift and ask her about any procedures she may have performed before the symptoms developed. Anaphylaxis is the most dramatic and life-threatening example of type 1 hypersensitivity reaction. It does occur rapidly. Five minutes later, the patient continues to experience shortness of breath. She states that she is feeling anxious and frightened. What is the appropriate nursing intervention? So, ABCs. Once again, you're going to assess the patient for signs of respiratory distress. The patient has swelling of the lips and eyes indicating angioedema. She is short of breath and may have abnormal breath sounds such as crackles and wheezes. Respiratory failure due to swelling of the tongue and larynx may soon follow. Emergency respiratory management is critical during an anaphylactic reaction because severity increases with time. This is the time to call the rapid response team to establish and stabilize the patient's airways. What therapies does the nurse anticipate the provider will order? So, epi, Benadryl, IV fluids, and oxygen. If the reaction is severe, the provider may order the first-line drug, epinephrine, for the patient. Antihistamines such as Benadryl are second-line drugs and are usually given for angioedema and hives. Acetaminophen would not be indicated. IV fluids are usually started when a reaction is suspected, and the provider may order oxygen to address the patient's shortness of breath. Here's some key terms that you do need to know and understand for testing purposes. And that is the end of Lecture 2 for the immune system. If you have any questions, if I've confused you, please make sure to shoot me an email. Have a great day.